Well, welcome. I wanted to start off with the new summary I'm going to try to provide on a regular basis. At the top we'll have last week's to-dos, and I'm working on trying to keep these summaries up to date. If there's a doubt or whatever, I may update these. I'll let you know by email if these have been changed in any way, but you can use this as a summary. So this is for the class, and I've dedicated a page to that, and in the laboratory. We're going to go over Chapter 9, which is on controlling organisms, and we want to complete the Chapter 9 worksheet and just email it in once you've filled it out. And I may highlight, as I have with this table 9.1, some of the key features that I really wanted you to know, and so that way there's not a black hole in terms of all the things you have to study in depth. This is a key one, so I'm going to be trying to do that on a regular basis. I will be posting the take-home exam this week, and within that I'll put the time for exam 3, and I got to figure out the best way to do it. And I'm working on it. I have some good ideas, and we'll do that. And I may or may not post a case study this week. I'm trying to debate. I don't want to overload everyone. I know this is not your only class, and it's only the second week of having these sorts of things, so we'll see how it goes. Okay, so the laboratory, we've got of course the lab, the staff and strep. Looks like everyone did fine. I'm not going to be too picky about times when you turn it in. Do your best effort. It looks like the majority have already turned it in. And I've looked through some of them. I'm going to be going through the rest of them today. I've been trying to solve a sound problem, and apparently it's working now. I hope it is. The lab, I'll be working on the voiceover again. I've already recorded it, but there's no sound, so I got to do it again. And then the lab manual, portions to fill in, and I did it in Word so you can fill it in best you can. And I tried to greatly simplify what has to be done. And there's a separate sheet which I'll update on this list for identifying the unknown. And should be straightforward. I hope that you find it useful. It's really hard to do this in lieu of not having it in front of me, and I know that's a moot point, but anyhow, so there'll be one other is a unknowns worksheet. It's only one page or two. I forget how many it is, but the idea is it gives you the data for the unknown, and then you choose on a table I provide with the results and things that make sense. So it should be fun. Actually, it should be straightforward. It does represent somewhat of what a diagnostics manager does. Once the data comes in, the manager will take the data from the field or from the med techs, and then fill out the forms. I think I showed you what a form looked like during one of the labs, and they make sure it's fits all the parameters and looks at the actual data. So that's what you're going to see, some simulated actual data. And then before he signs or she signs her name to the sheet approving a supervisor, all those things have to make sense. It's really important to have these double checks, because if there's a mistake, maybe it could cost someone's life. So the idea is I just want to get you some experience in doing that. We're almost done with this lab part, so all we have are the anaerobes to go next, and I'm debating or whether or not to add this other section some of the other groups are doing with the CDC, and I'm debating whether or not that's actually useful or not, but I'll get back to you on that. I might put that out as a poll question for you, for everyone there, to see if you would be interested in performing it. It's an interesting task, but I don't know how valuable it would be, and so I'm looking into that some more. So anyhow, that's the lab, and then we'll have a lab practical, and however that'll work out, I'll do the best I can. And again, this is best efforts. I realize that it's not under the best circumstances, but that's okay. You're going to find in your career that you're going to have to work in under extreme stress and pressure. Some of you are already doing that under this virus thing, in working 18-hour shifts and the like. So get used to it. This is the profession you pick, but it's a noble profession. So anyhow, let me know if this summary works, how much more information you like on there. The timing, I don't like to set right now solid times for you to turn it in. It's normally a week. As I say, it's 1 week from the assignment, but it really depends on your schedule and how things are, and so I will accept it right up to the last day to give you credit for these things. That's how flexible I'm trying to be on this. I don't know if the other instructors are doing that, but I think it's important to do that. So let me move on now to the main presentation, and we'll go through that. All right. So what we want to do is define what sterilization, disinfection, and decontamination, antisepsis, and degermination. Now, I'll start off right away saying that I don't like the word germ. Germ, I had an instructor at the vet school that absolutely, it's like pushing his hot button. A germ doesn't mean anything, and it kind of got drilled into me, and I refrain. I try not to use the term. A germ is sort of slang, and it's not very descriptive. So anyhow, so we're going to define these things. We identify microorganisms that are most resistant, least resistant to various different control measures. Well, we got to know what our goals are when we do the control. That's really, really important. When someone asks you to decontaminate or sterilize or whatever, you should have a good understanding what it is, the goal is in that process, to make sure it's done properly, and how much you're packing. We're going to talk about that and that sort of thing. Then we can compare the actions of these microbicidal and static agents. And there's a difference. And cidal kills, but not all. And static just doesn't allow them to grow. And we're going to talk more about that. And then we're going to talk about cellular targets for physical and chemical agents. So we have our work cut out for us, but it's a good thing. So this video will be in two parts, part 1 and part 2. Okay. Controlling our degree of exposure to microbes, really, we as workers, you want to protect yourself and you want to protect your patients. So these are the terms. Now, let me warn you again, it's a moot point, but it's one that has to be made. These terms are universal, but the rules and SOPs, standard operating procedures, within the hospitals and places that you work, define these terms and their exact meaning. So it's really, really important that you review those to make sure that you're complying and doing various things. There's how to use these types of chemical measures that are written out on SOPs. They may even override the package how to use, written right on the bottle or in the box or insert. The hospital decides on how these are used. They have best procedures. They've worked out best practices for that, in terms of an SOP. So always use whoever you're working for, whatever organization it is, use their standard operating procedure for using these types of chemical measures, and because you don't want to get in trouble for those sorts of things. Here's the chart that I was referring to. I do want you to know this kind of summarizes this section, really, this part one of the sorts of things we're going to talk about. But one of the things I'll state from this, the term sterile should be used only in the strictest sense to refer to materials that have been subjected to the process of sterilization. And so if you say the word sterilization, that means it's gone through the highest level. So it's usually to eliminate spores or prions or whatever the institution that you're working for stipulates for that. Now, I've seen all sorts. The vet school had a certain timing difference I've never seen anywhere else on their autoclaves. We were at autoclave, normally 15 minutes would do it. We had to do it for 21. And I don't know where that time frame came from, but that was what they decided, SOPs, within the organization. So that's what they were done at. Bleach, iodine, various things for disinfection. Again, you use the materials or the chemicals as stated by your institution, and they will differ most likely from the label on how to use. Now, this has practical where they've done a lot of study or research on various things. So this chapter can be dangerous if we just take it from face value, but really you follow the SOP instructions as dictated by your wherever you're working. If there are none, you ask for them, and again, if they don't have them, then you follow the directions on the substance or the control substance that they ship with whatever it's given, but only when there are no other instructions to go by. Soaps, detergents, and commercial dishwashers are decontamination or sanitizing. It's totally different. It's really sort of a cleansing technique that removes or reduces the number of microorganisms. And this is just common sense. So the decontamination, sanitation is common sense, really. The SOPs are probably there for even those sorts of things. I mean, you see those signs in bathrooms, the employees must wash their hands, but it doesn't say how well. And we know, and we've looked at the idea behind, sometimes hand washing can be really kind of like wimpy, and it's better than nothing. So, but anyhow, in hospital environments, you want to wash your hands thoroughly, and there are techniques for that. Again, there's probably an SOP for it. At the vet school, I don't recall an SOP for that, but I thoroughly washed my hands because I had learned from surgery type of scenarios on how to wash hands as a surgeon type of procedure, and I just always used that. It's kind of how I did things. Antisepsis and degermination, again, I just refer to the term antisepsis. It reduces the number, involves scrubbing of the skin. Again, a lot of times pre-surgery, you would scrub your hands and then you would go into the soap and detergent or decontamination after that. So you're getting rid of mechanically things on your fingernails and various things like that. Any dead skin, you want to remove that around your hands and things like that. And so it's hand scrubs, and then you go to a decontamination, then you put your gloves on and blah blah blah. So again, it really follows with the institution. And this is a nice, useful chart. It doesn't have the meat on it like the previous one, but it does help you look at physical, chemical, and mechanical removal of these types of things. So you have heat, and they're really important, the difference between dry and moist. Some of you are wanting to be dental area, whatever your expertise will be. A lot of times they use dry sterilization techniques for various things, and then they also use autoclaves or moist types of steam under pressure, boiling water, things like that. Now, in other food industries, may look into pasteurization and just using hot water for various disinfection needs. Radiation is usually used for plastic type of devices or devices that cannot be heated or exposed to moisture, and so they'll use gamma radiation typically for these. Now, a lot of times they'll use that for medical devices like heart implants or valves and various things like that. I guarantee that they're sterile, but it's ionizing, and so they'll do that. Very rarely is anything that has an electrical component to it that's disinfected by moist heat under pressure. It's usually ionizing radiation. Now, even that could be dangerous to non-volatile RAM and things like that. So there are other techniques that could be used, gases and various things, but my guess is that they made them rad hard. In other words, they can withstand the gamma radiation or survive it and still be functional. So it kind of depends, but again, SOPs, institution, you don't have to make the call. Let the institution take the heat if something goes wrong. That wasn't a pun, by the way. Chemical agents, gases and liquids. I've already referred to gases sometimes. A lot of times when I did animal studies, after I did the study where the animals were injected or whatever, we sterilized the room well. We sanitized the room is really the way I looked at it, using various gas bombs and things like that. Really toxic stuff, and so toxic in fact that no one would be allowed to go into the facility for a week, and so there's downtime for a week. UV and things like that have replaced some of that, and then using more modern type of techniques. Even simple things as having nickel plated surfaces, they tend to be antiseptic, and you'll see more and more of that in hospitals where they have nickel and silver. Nickel is actually a surface that you plate silver on, so it sticks better, and you can use thinner coats. Silver seems to have antimicrobial activity. I know people that use a silver tooth. When they go and have a dentistry done, they'll say, well, doc, I'd really like to have this filling or that tooth cap as silver. And then it's amazing. It will change the chemistry and the biome of the mouth. Now there are papers on that if you're interested, for those who are interested in dentistry. I find that a very intriguing concept. And in the old days, they used to flip silver coins in milk containers to cut down on milk spoilage. Now, it wouldn't prevent it, but over time, it's greatly slowed it down. Silver is an interesting compound, and how it does certain things. So, anyhow, we can't spend too much time on that. Liquids, there are disinfectant. There are some sterilization that you can do with liquids on inanimate objects that usually have to immerse them. Again, they're probably not going to have electronics on board. It's some of the new things. Filtration is one of the areas that I kind of worked in for a while. Ultrafiltration, large-scale ultrafiltration. We used to separate things, blood components and various things like factor VIII and factor IX, blood components using high-pressure chromatography. These filtration is a very, very interesting art. You can decontaminate air using HEPA filters, which is part of the laminar flow hood technology, and I'm going to go over that. Liquids, you can sterilize. It really boils down to the pore size, and the problem with doing filtration type things is the pores will get clogged, and there are filters that they use what they call laminar flow, so it's tangential, so you can have pressure going in, and then it reroutes the flow so it goes across the membrane, so it tends to flush it. Things that clog pores, it just kind of washes it around. and so you'll get at least some filtration going on. So it depends on the pore size. 0.45, 0.22 micron, those sorts of things. Those, even at that size, would allow viruses. So again, you have to understand what your goals are in terms of decontamination, and especially when it comes to filtration, you've got to really know what you're doing and why you're doing it. So as trivial as this chapter may appear, there is some really good things in here to think about, and for us to get under our belt. It will help your career, it really will, understanding some of these control methods, because this is always a problem. Nosocomial infections, just having contamination in hospitals in general. And I know in the old days, I used to run a crash table. I was hired as a sort of just as an orderly. That's a high title. I got all the code browns, you know, all that great fun stuff. I lasted about 6 months, about all I could take. I could tell you stories. I'm sure some of you that work in ERs can do the same. But the crash table, I had certain. It was a crash cart. We call it a crash table, but it's actually technically a crash cart. And it had various things. If somebody had a stat emergency, that they would have to have certain stocks to have various things, like a trach tube, various different sizes and things like that. And it had better be there, or someone would die. But things would have to be sterilized, cleaned, sanitized. Depends on what the objects what the objects are, and how they're being used. So things as simple as that, and they have SOPs for all of that. That was my first year out of high school. I worked as an orderly, and it really opened my eyes. That I'm glad that I didn't choose human medicine. I wanted animal medicine. It was better all the way around for me. It was more pleasing for me. Sterilization process is the destruction of bacterial endospores, and that's the key. You're after endospores. Now, you may be in research. Research may have, going after prions, or those sorts of life that may be more tedious, which proteinaceous. If you look into prions that are a little bit maybe tougher than spores and still have some activity. We're not sure about some of those, but depends on the environment. But most of the healthcare environment, you look at spores. Again, you follow the SOPs of the facility. So there's prions, the most resistant, and then you have enveloped viruses, because of course when they're enveloped they can desiccate, and then they become useless. And so non-enveloped viruses that have particular adherence things are more resistant, and apparently the new virus that we're dealing with may have characteristics that can survive desiccation for a period of time, which is troubling. And then you look at the bacteria and then protozoa. Some of the gram-positives are more resistant, like staph, and then you look at mycobacterium, which is sort of in between. It has a weird membrane to begin with, and then you get into the endospores, which we'll talk about briefly. Comparative resistance, endospores, vegetative cells to control agents. You look at the heat, 120 degrees C. Endospores are about 2 times more resistant than regular vegetative forms. If you use X-rays, 4,000 grays for spores, that's pretty high. I'm going to show you some comparative measures for radiation, and again, it's just a tip from your Uncle Ed. My guess is that you're going to be coming into contact with radiation, various things. I did. I got a really bad experience when I was going through my training at Wellcome, Burrs Wellcome, and I was exposed to a lifetime dose of radiation. And so I got to know these terms intimately, because I can't work around these sorts of things. And there are some working levels that, I guess I can consciously make a decision to do, but I wanted to convey that, so that's one of the things I wanted you to kind of look at today. Radiation X-ray levels, the nomenclature is at first confusing, and I have to tell you, they do it for a reason. They don't want you to know, and I want you to know. And so there's certain terms that I look at are standard terms like grays, and it used to be REMS, there's all sorts of various things. And it boils down to how it's measured and what it goes through. In other words, what type of tissue and that sort of thing. I'll try to go over that. Ethylene oxide is the gas that we use in the animal facilities when I was in school. It is a really nasty gas, and if you look at vegetative form, 700 milligrams per liter, that's not very much. It's pretty toxic stuff, and ethylene oxide is a very strong oxidant and basically renders proteins useless immediately. It's really nasty. Sporicidal liquid, glutaraldehyde, is the same as it's used for embalming fluids and things like that. 3 hours for endospores, 10 minutes for vegetative forms, and they're 183 times more resistant with these sporicidal liquids. So just to compare, and let's look at the radiation just briefly here. The conversion factors, we have Curies, Becquerels, Grays, Rads, REMS, Sievert units. So just to look at the quantity, radioactivity in itself is somewhat measured in a Curie. One Curie is 3.7 times 10 to the 10th Becquerels. I don't see people using Becquerels unless you're in research very much. The absorbed dose is the amount that actually is would be absorbed as a gray or rad. That's usually what you would be concerned about with radiation badges and things like that. Or dose equivalent is your Sievert or REMS, and those two have different uses for absorbed and dose equivalent dose. And so it's confusing, and so I stay on the grays. I focus on that, and then from the gray you can kind of convert around. But just to know, exposure to cosmic rays during a round-trip flight on an aircraft in grays is about 0.03 milligrays, and then you can see what the doses are in the other units. But I focus on grays. Just threshold for increased risk of early death, 2 grays. 50% chance of death, 4 grays. Early death, all but certain, 6 grays. So I think that helps. I have a little bit more here. Fatal within weeks in millisieverts. So this is a different unit. You're looking at 6,000, 5,000. Now, a lot of times the news people will report in sievert units, and you can see that Fukushima plant, maximum radiation was 400. The recorded at Chernobyl was 6,000. So it kind of shows you the difference. And there's the film badge, and it's literally a piece of film. And it's X-ray film. And it's the same X-ray film as you would for a patient with an X-ray in the old days. Now they use a photosensitive cells that react and can create an image immediately. But they still use film, and what happens is upon exposure to radiation, it'll darken. Well, actually, it receives, so it changes to silver, so it clears. Excuse me, starts dark, and then it clears. And then they have a device that can measure the transparency of how much light gets through, and then they can calculate how much you've been exposed in dose. And so that would be converted to Becquerels or grays is what I always wanted to look at. So anyhow, you should wear those badges. Insist if you're going to be around that you have to wear them. It's by law. Agents versus processes. Now remember the title, agents versus the process. Sterilization, disinfection processes. So sterilization is a process. In other words, there's various things that are going on, so it's a process. Disinfection, same sort of thing. Bactericide is a chemical that destroys bacteria, except for those at endospore stage. So that is an agent. A fungicide is an agent. It's a chemical that kills fungal spores. Viricides is an agent, chemically known to inactivate viruses. Clorox is a viricide. Sporicide, an agent capable of destroying bacteria endospores. That's an agent. Germicides and microbial are chemical agents that kill microorganisms. So processes usually involve more than one factor going on at one time. So you have to get all these processes together. I know it's a moot point, but that terminology they're going to throw it around, and you just get, it's like learning Japanese. You have to understand these little slight intonations and to make a difference, like Beijing versus Beijing, haircut versus hospital. It could be a little disturbing. I mean, you just went for a haircut and you end up in a hospital. In this case, you want to know if it's a process or an agent, and it talks about, of course, how it would be used. So process method is sterilization. All microbial life is killed. High-level disinfection is a process, but no, it doesn't necessarily have to kill endospores. Now, they assume, unless you know for 100%, so they'll say no. If in doubt, say no. That's kind of a rule. Anyhow. Sepsis is the growth of microorganisms in the blood and other tissues. Now, sepsis is evolving because of PCR and other diagnostic tests, which we haven't really gone into at all, and we won't. But that doesn't preclude you from studying it on your own. Polymerase chain reaction is pretty common these days. But PCR can pick up very, very, very small amounts, detect DNA at the nano scale, and we can detect if the presence of a microorganism or not. So we're finding out that our blood is not as sterile. We get transient infections all the time, and our immune system quickly, or without whatever its standard timing is, gets rid of it. So we're constantly sort of pulling chains, I guess you could say, in our immune system to keep it primed and ready to go, and you know, it's like practice runs, or when we take our battle fleet out just to show the world we have the power. Well, it's the sort of thing is that we have a little transient infections, and the immune system immediately goes into mode to get rid of it. So it's a good way to kind of make sure things are going. Asepsis is a practice that prevents the entry of infectious agents into sterile tissue. So we practice aseptic technique during surgery and various other procedures. It's really, really important, and that's why it's one of the key things that I try to convey for you in lab. It's just a very important thing. How to identify sepsis? And I chose pediatric because I found this British one, it's really quite good. Core temperature increases, which will go concomitant with increased respiratory rate, because your increased temperature means that your metabolism is increasing, therefore oxygen utilization is increasing, so you'll see increased respiratory rate. Inappropriate tachycardia, and the problem with that is it's invariant. It can go high, super high, high, down to normal, then super high again, or something like that. Altered mental state, a little state of delirium in children. Now, I could flip this and say elderly, and it would be pretty much identical. Prolonged capillary refill, so all you have to do is just push on the skin, it turns white, and then you want to see it perfuse. And reduced skin perfusion, that lets you know that something's going on, and capillaries are involved, and we have inflammation. And patients younger than 3 months, of chronic disease, recent surgery, immunocompromised, high risk. Elderly, have gone through hip surgery, or they're on immunosuppressant drugs for whatever reason, they are high risk. So immunocompromise is something you always look for in charts. I'd circle it, highlight it, make sure that you're taking the right actions. So the sterile fields in surgery, I'm not going to go over that, but really, really important. Those environments, those theaters are really highly controlled. It's up to the surgeon. The surgeon's the one who's running things. It's his circus, and he's responsible for everything. And if something goes wrong, it's his fault. Even if he didn't do whatever it was, it's his fault. And so just understand, doctors turn into Dr. Jekyll and Mr. Hyde sometimes in these fields because it's so doggone stressful. And so there's a critical sterile area right there. If you're working in level 1, that's what they refer to it as, you are a high-paid personnel and somebody who's highly trained. So antiseptics, chemical agents applied directly to exposed body surfaces. So if you're going to, it's like putting iodine on, where you're going to inject somebody. Now technically, if you read SOPs in hospitals and things, it's supposed to set for 10 minutes. Nobody does that, but it's there. And it takes that while to penetrate and make sure, our skin is somewhat impermeable. Of course, it's waterproof, and you want to sort of let it sit and get in there and do its thing. But nobody has time for that, so we rub it down saying, there you go, I can see it on the skin, and bingo, you go in and put a needle and that sort of thing. Again, SOPs are really important. So, agents versus processes. So, preparing the skin before surgical incision with iodine compounds, betadines, or whatever it is. Swabbing an open root canal with hydrogen peroxide. Ordinary hand washing with germicidal soap. A lot of times you'll see a patient would be draped, and the skin may have a contact on it, so that it's a barrier that's not normal. Just as an added precaution on top of the skin, that's already been betadined, and so it's really gone through amazing evolution. Stasis and static mean to stand still. Bacteriostatic, chemical agents that prevent the growth of tissues and various. Fungistatic, chemicals that inhibit fungal growth. But as soon as that chemical is gone, the fungus will start growing. Antiseptics and drugs often have microbial static effects because microbicidal compounds can be toxic to human cells. So we got to be careful. It's a give and take. There's a balance. When you take pharmacology, you're going to certainly learn all about that. And they have terms and formulas calculating all that stuff. Even a cytal agent doesn't necessarily result in sterilization, depending on how it's used. And everything depends on how it's used. So skin preparation, a lot of times the area is large, and then you put a sealant over that, some sort of adhesive. However, the hospitals do it, or how the surgeon prefers. Every surgeon's a little bit different. The physician's sterile techniques, they go through their little sort of routine that they have to do to put on their gloves and gowns and all these sorts of things. And there's rather a lot of times nurses will assist in putting on because of touching and procedures and how you do things. And then even all of the assistants go through the same sort of thing. Critical medical devices expect to come into contact with sterile tissues must be sterilized. So we use those techniques that we talked about, or the methods and the procedures in terms of x-rays, gamma radiation, or using autoclaves or steam, hot steam. Semi-critical devices come in contact with mucosal membranes. They must receive high level of disinfection. Now, the hospital may require sterile. It depends. SOPs, find out what the importer wants. Non-critical devices that don't touch patients usually require low-level disinfection, but again, just follow the SOPs. Biofilms are really a huge problem, significant cause of morbidity and death, and a lot of times, of course, we're opening up areas that the body never gets opened up and exposed to various organisms that would never find its way there. And these are not clean. They're supposedly clean and sterile facilities, but unfortunately, it doesn't always pan out. Staph aureus and Staph epidermidis are the most frequent causes of biofilm associated. They usually are the first ones that set up the association and allow other microorganisms to stick to it. Indwelling, in other words, ones that they leave in the patient, sort of like a hip replacement or a valve, a heart, or all sorts of stents and things like that. We got to be really, really careful, really high level. A lot of times, like stents will have antimicrobials baked into them or things like that to try to cut down infections and blockages and fissures and things like that. But it's getting better and better all the time. And so, like cardiac catheterization, and it goes in through insertion site in the femoral artery. So it's down in the pubic area, and of course it's not the cleanest area on a human body, and so that requires a certain SOP to make sure that area is cleansed and set for the procedure, because you don't want to be introducing the types of microorganisms that usually exist in those areas near the anus and things like that that normally wouldn't find its way into the heart. This, you could see, would be a perfect path for that to occur. And these types of devices, of course, pretty invasive, and so it's doing what they need to do, and I totally understand all of that, but it really is up to the surge techs and folks associated with the surgery to make sure these things are absolutely sterile and handled that way. So usually procedures would be shaving and sterilizing with chlorhexidine around the groin or wrist or whatever. Preoperative neurological baselines is established. Conscious sedation is typically administered. Fentanyl, and they have these drugs, it's amazing. Nerve blocks can be used, all sorts of things you'll see. Access is obtained in the radiofemoral artery. Different sized catheters are introduced in the vessel. And they have all these different sizes and targets and various things like that. But the problem is, a lot of these microorganisms can colonize needleless connectors, and some of the things that we make easy to facilitate turns out to be our enemy because of these biofilms. And so a lot of the connectors and various outside devices will be silver or other types of surfaces that are treated specially to have antimicrobial activity. Here's an indwelling device. It's of course the hip replacement. My mom had both of her hips done at the same time. She was quite something. But replacing is very invasive. I mean, they will literally cut off the femur head and grind that up and then place that into the fitting down at the base down here to provide cells that will start to form new bone. And this is usually fritted to some degree heavily so that the tissue can integrate into the stainless or the types of materials that they use. It varies, but the idea is that you want it to hold really well. But look at all the various potential biofilm locations. The heart, having the breathing apparatus, of course the hip itself, insertions for various types of medications, or in the arm. All these things are factors, and I just wanted you to be aware. Medical devices that all have to be sterilized, and they're usually in packs and layers, and so all the procedures are well known, and I tell you, these surgeons are really picky, but hey, you know, it's a really high stress job. And so as you go down a pack, it's the instruments that he would use during a surgery. So the first unwrapping would have the level 1 type surgical devices, and then you unpack those. They're used up and gone, so you unpack the next layer. And so you're not moving from pack to pack, it's all in one pack. But you got to sterilize and set the time to be able to functionally sterilize that whole package. And you do it with indicators throughout, so that you know if there's an indicator that hasn't turned during surgery, that's bad news. Unless you got another pack backed up, ready to go, it could preclude a surgery, and you want to talk about really having one upset surgeon, that will do it. And so here's the packs I'm referring to. You can have these clear wrap, so you can see it, and it'll have some sort of tape on it that turns. You can see here's tape that's been autoclaved. You can see it turns black. And towels and various things. Here's an autoclave over here. But the packs have a certain technique on how they're done, so that you don't contaminate when you open them. So there's these flaps that are existing. The idea is you don't want to touch anything, even when you have gloved hands and all that stuff. You want to minimize the contact as best you can. Now think about how invasive a hip replacement is. Locations, you know, around areas that are not all that clean, and it's hard to get into these, and they literally hang the leg up. They tie it up to the ceiling so it gets the weight off the leg, and then they cut the femur heads with saws, and oh my god, it's quite something. And they screw in various pieces and parts, and oh my, it's quite an invasive technique, but it's done all the time. Here's some of the equipment, and here's where the integration of some of the tissues can dig in and sort of make entries into these areas. Now, the problem with that is, yeah, it does wonderful for getting the surfaces to engage with the human body to get calcification, so that it holds it in place. But think about all the nooks and crannies that microorganisms can be in there, and it's hard to make sure that all these areas are clean. And especially when you're holding it and, well, it didn't fit right, so I got to put it back on the table and drill some more or saw some more and then go back and try to fit it. Well, you're running the risk, just like an open plate. You leave that top open, eventually you're going to get a contaminant. And a lot of these contaminants are the types that form biofilms. And I've seen femur head necrosis. That's a staph. A staph can do it. E. coli can do it. And it literally makes it like paper mache. It's disgusting. It literally waterifies, and it just becomes useless. I hope we never see that. So substances that require sterilization, durable solids to sensitive liquids. So you got to be careful about boilovers and all those things. So you have to exhaust them slowly so they don't boil over. And you have to do various things that are cost effective, and the methods of disposal, all the sorts of things that you deal with. You don't want, you want to use gamma radiation because there will be no residue, things like that, but it's expensive. So let's talk about microbial death. It's a permanent termination of an organism's vital process. Microbes have no conspicuous vital processes, therefore death is difficult to determine. It's not like you can measure brain waves of these things. Hey, and they can be like possums. They can play dead. They may not appear to be growing. They're kind of in animated suspension or suspended animation. And they can trick us. I've seen this in processes in pharmaceutical type things where they appear to be dead, but they're not. And I can call their bluff, and I can grow them out. Permanent loss of reproductive capability, even under optimum growth conditions, has become an accepted definition of death. In other words, there's certain procedures to try to get them to grow, assuming your technique is excellent, your aseptic technique, and if nothing grows, then you can say emphatically that it's dead. Now, keep in mind the number of living microbes. Microbes are unusual from the standpoint they can go 10 to 15th. That's a lot of organisms. Now they show 10 to the 9th, which is pretty standard. but they have a rate of death, and you can kill. And the thing about this is, once this has been worked out and you follow the procedures, then 100% chance that you won't have anything growing after that. It's been worked out. Now, if you deviate any at all from the procedure, all bets are off. So just keep in mind the types of things that we're after in our goals. Death of the whole population is non-instantaneous. It begins with a threshold. Death continues in a logarithmic manner. Now, obviously, the younger ones survive better. Active cells tend to die more quickly because they're taking up. However, some of the younger ones may shut down processes metabolically and become less active. Now, older ones do the same, but the problem is that they're close to their expiration date. So eventually, a point is reached which survival of any cell is highly unlikely. The point is equivalent to sterilization. So these things have been worked out where they've done procedures and times and all those things, and you follow those, and then you don't have to worry about it. But if you deviate just by a little bit, all bets are off. Number of microbes, the high load of contaminants takes longer to destroy. That's common sense. This term of bioavailability, I heard that so many times. Well, it's bioavailable. The chemical didn't get to it because the bacteria had packed in so tight and that sort of thing. Target population is usually a mixture of bacteria, fungi, and spores. Temperature and pH of the environment, all sorts of things can affect these. So all those have to be taken in consideration. If you're using UV radiations effective at 260 nanometers, because of course that's what damages the DNA or causes thymine dimers we talked about. Most disinfectants are more active at higher concentrations. Hey, common sense. Mode of action of the agent, how does it kill or inhibit? The presence of solvents interfering organic, there's the bioavailability. In other words, if you have lots of organic matter that's going to interact with that agent, then you're essentially diluting it. Think about that. If there's a lot of bioactivity going on and you apply the chemical agent, maybe half of it is actually being introduced where you needed all of it. So sometimes as a matter is that they'll go with a measure to go overboard in terms of concentration. Saliva, blood, feces, all of those things can inhibit the actions of these disinfectants. Antimicrobials have ranges of cellular targets. Least selective agents tend to be effective against widest range. Selective agents target only certain type of cellular components. Cellular targets of physical and chemical agents are cell walls, cell membranes, anything that we can disrupt the integrity of the cell membrane is what we're after, spew out all the contents. Cellular synthetic processes and proteins, if we can denature those irreparably. So here is a list of table 9.3 of actions in various physical and chemical agents. I'm not going to ask you lots of details. Just be aware of the cell walls, membranes, and the synthesis of proteins as a general concept. The types of agents used, I'm not going to ask you to worry about that. So, targets of physical and chemical agents, you can see surfactants. That's a term I do want you to know. It's a soap. A surfactant has the hydrophobic, hydrophilic characteristic, so it disrupts membranes. It has both, and surfactants will do that. It's essentially a soap, and soaps have both. Physical agents, heat and radiation can cause damage to the integrity. So here's a concept check. Use of iodine compounds known for the skin surgery is known as what? A disinfection, antisepsis, sterilization, sanitation, or degermination. And if you said D, you were right. We're sanitizing. And again, the definitions, we have them that are in the book, but again, it's more important the definitions that you place at your work. Iodine sanitizers, iodine's been used for lots of things. The betadines, they have all sorts of names for these, but iodine is more stable, less corrosive, less volatile in various solutions. And that's all I wanted you to know, is the iodine is cheap, it works very well. So I'm going to stop here, and we'll pick up next time part 2 of getting methods, the moist heat, define the times, the thermal points, and the various different types of controls that we use in a little bit more meat and more detail than I have up to this point. So we will pick up at this slide next time, and I enjoyed having time with you. And the other videos, I'm redoing the video for the lab, so that should be forthcoming shortly.